So the thing with those people is that they are not only at a very high risk of stroke and cardiovascular events, also medication compliance and adherence is a big challenge. And Hanne, I would like to ask you, how do you balance the intensity of the treatment, the tolerability of the treatment, and adherence to it? Do you perceive that those goals are actually competitive, independent, or they are synergistic?
Well, basically, I think this is a lot about communication. And I think that it was very important what Jesse just said about reassessing why did this person have a recurrent stroke. And I think that we should always keep our minds open that we may not have reached the right result when working on patients. And I also think perhaps even more importantly that most of our patients, they have signs of more than one stroke pathology. They often have both small vessel disease and large vessel disease, or they have atrial fibrillation and atherosclerosis. And so this means that sometimes we may have to think a little bit pathophysiological, which I otherwise do not like, to identify exactly how to go with this patient. But I think this is about compliance. I think this is about information. It is about motivating patients beyond the fear of the acute event, because the fear will not last forever. Most people are very optimistic, and I don't think, and most normal people will not be able to keep up the fear for more than 2 or 3 months. So you need to find their own motivation to go to somewhere where their risk is lower, and they might even keep up their functioning, because that is what people fear whatsoever. Everybody wants to be able to walk and talk. So I usually start telling people about what the benefits will be. I usually talk about the risk reduction. I usually say, and this is based on some kind of evidence, but of course not completely precise, that if they do exactly as they're told, they will have about 80% reduction of the risks they would otherwise have for another stroke. And this bears the optimism of saying, look, you can do a lot of things, because at least Danish people have some kind of a feeling that stroke is something which happens and then it will continue happening whatever you do. And I think that is what you need to deflate. A lot of people are concerned about medication side effects, but they're also very concerned about things which will inevitably happen if you give people a diuretic. There will be a peeing problem, and people do not, and they might feel they have to stay indoors all morning because they have the diuretic in the morning. And you need to discuss these things. Otherwise, they will stop taking the diuretic, at least in these days where they have to do something. And the beta blockers and the sexual functioning, especially in males, is another issue that you need to discuss, because otherwise the patient will simply stop taking the medications. And you need to listen also to their impressions of what happens from side effects, because if you don't listen, the patient will not feel that they're taken seriously and that their complaints are actually evaluated, which is very, very reasonable, even if we do not have their complaints on our lists. And then I think you need also to be willing to attack the overall medical chart, because polypharmacy is always a problem. And even though all three of us agree that the pills we are advertising at the moment are really, really important, and that's what I feel too, patients may end up with medical charts of, 14 or 16 different medications. And that is never healthy, because this will end up in something which is uncontrollable. So I think you must, as a stroke physician, seeing these patients who usually have comorbidities, at least to start taking a look at the medications and reducing the list, because that will often make the patient much more willing to start another pill if you can take one out. Then I think that these combined pills, we use Losartan and diuretic in one pill a lot in Denmark. And this it really works very well because it's simpler. also the thing that we need to give 2 or 3 daily dosing is not always really needed. It may be optimal, but having the medications may be better than having it at the optimal timing. So sometimes it's about giving the medications once daily, all of them, in one bulk in the morning, which is often possible, even though statins are better in the evening. But still, in the Sparkle trial, there was not a defined timing of the dosing. Maybe very helpful. And then always check for interactions, because if you give the patient a side effect because of an interaction that you have not thought of, you will not be popular and you will not be listened to. And then there's also the interactions of natural medicines. At least in Denmark, a lot of people are using so-called natural medicines like Pericon for depression, or St. John's wort for sleeping. And these have a lot of interactions, also to the drugs that we're using a lot. So talk to the patients, listen to them, find out what they are using, because the patients must live with their medications and they actually have the chance of forgetting every day.
Thank you so much, Hanne. These are all excellent points. And in fact, you did bring up 2 major things. One is communication with the patient, and also is lifestyle changes, both very important, but unfortunately overlooked. So I'd like to ask your strategies. What have you found to be the most effective in actually communicating to patients lifestyle changes, diet, exercise, smoking cessation, but more importantly, making sure that those changes are going to be sustained for the patients and the individuals?
Do you know what? In general, I don't think doctors are very well prepared for discussing lifestyle, and in terms of education support. Right from medical school, we're not really taught about nutrition. We're not taught well even during medical training, whether you are internal medicine or surgical training. There isn't that comprehensive coverage of nutrition, physical activity, exercise, sleep, etc. And the WHO last year, the Global Stroke Fact Sheet said that up to 84% of strokes can be preventable by optimizing modifiable risk factors. Obviously, it doesn't always mean that we can, really prevent 84% of strokes, but I think it just emphasizes the importance of lifestyle education and support for the patients, for that empowerment. Lifestyle medicine it's now actually taken momentum to be a separate specialty altogether now. And for stroke patients, I think we are really talking about adopting a Mediterranean-style diet because it has polyphenols, it has antioxidants, it has plenty of fiber, and it promotes avoidance of ultra-processed food, high fat, high saturated fat, and also red meat. So that is kind of one of the pillars of lifestyle medicine. Another one is increasing your physical activity and exercise. And people often mix those two things together. Physical activity is what you do during your waking hours. So whether you are standing up or sitting down in the office, walking up and down the stairs in the house, or just, cycling to work, for example. Whereas exercise is your defined period of higher intensity physical activity with a clear goal of improving fitness. And then getting enough sleep, 7-8 hours a night of good quality deep sleep. Avoiding cigarettes and alcohol, managing your stress, and staying socially connected. Those are your pillars of 6 pillars of lifestyle medicine that doctors often don't have time or the knowledge to talk about during follow-up. And as Hanne already said about the WHO checklist, it has, or have these things within it to talk about during your consultation. My mantra is, it is everybody's business. It is not just to do with the nurse, go and talk to the patient. It's not just to do with a physiotherapist. Oh, can you talk about physical activity and exercise when you're walking them? It is everybody's business. And the doctor is quite often the person they look to with the highest respect to say, do this, don't do that. And I have 6 tips, if that's okay, 6 tips of effective education for lifestyle. The first one is setting realistic goals. Rather than saying, cut out all the cigarettes and cut out all your alcohol, or, reduce your weight by, 10 kilogram. We have to set more realistic goals, and you have to move towards those goals in a stable, steady way. Another one is involving their families and friends, because by doing it together in a household, it is much easier to give up, for example, high saturated fats and ultra-processed food when it's just not in the house to eat. You can't see it in the cupboard. Don't buy it for the whole family. So involving your family and friends in these lifestyle changes. Another one is reading your food labels. Always read your food labels. The amount of salt, the amount of saturated fat, the amount of sugar that you take in those foods. And deconstruct the food. If you pick something up to buy, you just deconstruct that and say, is it what I'm putting in my mouth good for me or not? What is it that's doing for me? And then another one is making it fun. You make it fun for the lifestyle changes. So trying new recipes, going dancing and ice skating for your exercise is much more fun than, burning 90 minutes in a gym. Making it a routine. So, for example, I tell my patients, just after each meal, go for a walk for 20 minutes. Then in a day, you've walked for an hour, and that probably equates to about 10,000 steps a day, making a routine and making it a daily thing. And then lastly, to keep track on progress. There is now more and more apps and AI that is letting you keep track on your steps, on your percent fat, on your muscle mass, especially if you use those scales that you can get probably very cheap nowadays. You can get one online for about £30, about 30 euros, to these scales that give you the percentage fat and muscle mass rather than just your weight or your BMI. Lastly, I think it's really interesting, the move towards GLP-1 that Jesse talked about. Optimizing your weight, it's so important now. And people reach for that easy option of injecting themselves. I give a bit of a word of caution to my patients about very rapid weight loss, because afterwards there is some evidence coming out now that you put it back on quite quickly when you stop the injection. But also another thing is, when you lose weight, about 30 to 40% of that weight is lean muscle mass. Mm-hmm. So you're not just losing weight, you're losing proper lean muscle that you use to run and to walk. So, when you use GLP-1, you have to pair it with resistance exercise and really focus on the amount of protein that you eat. Probably at least 1.2 gram per kilogram body weight per day, in order not to lose all that muscle mass. And my aim for them is to get fitter, not just get thinner. When you get fitter, physically fitter, you automatically optimize your weight, but it's also good for your mood and your psychology as well.
Thank you so much, Joe, for summarizing all the important aspects of lifestyle changes and also sharing your tips on how we can communicate better with our patients and achieve the goals for our patients. So as we're reaching to the end of this webinar, Jesse, I would like to kindly ask you to summarize the 3 most important takeaway messages for our audience.
Yeah, thank you very much. Now, I'm gonna take a liberty here, and I'm gonna give you 4 because Joe spoke so passionately there about lifestyle. So I'm gonna come back to that, which I think is great and really important. So I think my 3 takeaway messages would be: number 1, I think be appropriately aggressive. So aim for the targets. The targets exist for a reason, and if somebody isn't hitting those targets, act. But remember, and this is number 2, that we do need to be specific and personalized. We need to consider the whole patient, think about their comorbidities, think about frailty and other things. And the third one would be that we need to all think about our structures to ensure adherence to the medications and follow-up of targets, and take some ownership of what happens in the longer term with our patients and with control of their cardiovascular risk factors. So they were my 3, but I think it is worth mentioning, after what you've heard about lifestyle, a 4th one. Don't forget about lifestyle measures. Don't forget about giving people access to smoking cessation, simple things that might just make a difference. They won't make a difference to everybody, but even if you do it 10 times and one person starts the journey to stop smoking, it could be tremendously impactful.
Thank you, Jesse. Thank you, Hanne, and thank you, Joe. In today's discussion, experts have highlighted that secondary stroke prevention is not just about prescribing the right medications. It's more about integration, how we combine evidence-based therapies, lifestyle support, personalized care, and multidisciplinary collaboration. Thanks again to our panelists for this insightful discussion, and thank you all for joining us.